Hello and welcome to the Recovery Channel. I'm Dr. Richard Whitney, Medical Director of Addiction Services of Shepherd Hill in Newark, Ohio. We're talking about opiate addicts. We're talking about patients with the disease of opiate addiction. And what we want to know and talk about tonight is how do we treat people who are recovering from opiate addiction when they have legitimate other medical complaints like pain, anxiety, and sleep. But unfortunately, a very common way to treat these disorders is for a doctor to prescribe another addictive drug, thus triggering the patient to get back into the disease of addiction. And of course, what we want to know are safe ways to treat pain, anxiety, and sleep without triggering people to go back craving drugs. So let's talk about acute pain and chronic pain. Acute pain is something like, okay, I broke my leg, I'm having pain right now, I need some relief right now. That's pretty simple to understand. Pain that continues for weeks and months after an injury, spinal pain, degenerative arthritis in the spine, or broken bones, or back pain, or slip discs, but the pain goes on and on and on. This is chronic pain and generally is defined as pain that lasts longer than 3 months. So in people with the disease of addiction, what we understand is the brain and spinal cord and nerves work differently. Whether I'm born with it, or whether I develop it by using opiates for years, my body perceives pain differently. And sometimes I feel the pain even though the original injury has been healed. Also, when we associate distress and anxiety, which we all feel when we have pain, this can contribute to people saying, I want relief no matter what. Please give me release of my stress and anxiety and my pain. And in addition to that, we're caught in between a rock and a hard spot because an opiate addict will say, well, if you don't treat my pain, I'm going to go out and use opiates, but I'm scared to death to use anything to relieve pain because it might trigger cravings. So these poor people are really pulled one direction and another at the same time, wanting relief of pain but not wanting to go back to the horrible disease of addiction. So sometimes it's difficult even for the patient to understand what's pain, what's craving, and how's the doctor supposed to know? Well, it takes a well-trained, experienced physician to be able to treat this very challenging situation. Again, patients are being driven in two directions at one time. I've got relief of pain, I've got cravings, I don't know what to do, which direction to go. So the doctor's job, my job, is to say, I know you have the disease of addiction, but you're not going to suffer. My job is to safely relieve your pain. You're not going to have to suffer just because you're a recovering opiate addict. And we should treat it appropriately and properly, okay? But also explain to the individual, I'm also knowledgeable about your disease of addiction, and I don't want to get you back out using again. If someone comes in with a broken leg or a medical condition, we do not take them off of opiates. We use legal opiates rather than illegal opiates, but we do not detoxify people off of opiates until the acute injury, the appendicitis, the broken leg, the spinal fracture has been attended to. However, if they're also addicted to alcohol, marijuana, cocaine, tranquilizers, sleeping pills, obviously those people need to be taken off those medications safely, properly in the detoxification, while we leave the opiates on board for a later time. We also can use, believe it or not, techniques other than the prescription pad and pills to relieve pain. Many doctors forget this too. We have electrical nerve stimulators. We have regional anesthesia, which means numbing up of nerves in the legs and the arms to relieve pain, just like the dentist does for our jaw when they're pulling a tooth or we have a broken tooth. And this does not have nearly as many side effects as opiate pills do. But when they are necessary and used, a doctor knowledgeable about the disease of addiction should be consulted and brought on board. When we are treating pain, what we want to do is keep patients out of pain. So we schedule medicine regularly around the clock so people don't have to wake up and suffer until they get something to relieve their pain. Sometimes patients have what's called a patient self-administration button that they can actually, PCA, patient-controlled anesthesia, that will deliver the opiate drugs. And it seems like, wait a minute, won't an opiate addict keep pressing that button all the time? Well, there are ways to limit the amount per minute, per hour that people get. And actually, we find that people get less pain medication when they know they have self-control over the amount that they get. Very importantly, people who are in recovery from opiate addiction need to continue their recovery efforts. We have people come in, we have sponsors come in who bring a meeting into the hospital room or into the rehab facility room. We must address anxiety, depression, and other issues going on. Maybe people have wrecked a car, lost a loved one. We have to address the whole patient here. And sometimes people with chronic pain actually have become dependent on and addicted to the medication that we use. So it's a very delicate balance of using just enough and not too much. So what medicine other than opiates can we use, either self-administered or prescribed by a doctor, to relieve pain, either acute pain or chronic pain, in those individuals that have the disease of addiction? Well, we have a whole bunch of these medicines. NSAIDs are non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, which is Aleve. We have Sulindac, we have Clinaril, we have Dolabid. We have a wide variety, about 15 or 20 of these different medications in different categories. So we have a number of different ways to treat pain. These are very safe, very effective. We even have one that we can give by injection, which is equivalent to about 10 milligrams of morphine. It's called Toradol. So we have a lot of ways of alleviating pain without using narcotic pills. Antidepressant medication can be very effective. Now, we don't treat pain with antidepressants by treating depression. We treat because these medications that are sold as antidepressants also have other effects in the body that can alleviate pain. Okay? Arthritis pain, cancer pain, central pain, these medications have the beneficial effect of relieving pain. And we're not saying it's all in your head. We're saying that these medications have beneficial side effects. What type of antidepressants work well? Well, an old style of antidepressant called tricyclic antidepressants. These are named tricyclic because there's 3 chemical rings in their structure, so they're 3 cycles or tricyclics. And these have been around for decades. They've largely been replaced in the treatment of depression by SSRI drugs like Prozac, Paxil, Zoloft, and so forth. But they still, if they were brought on the market today, they would not be marketed and sold as antidepressants. They would be marketed and sold as chronic pain relievers because they can have very, very beneficial effects. An old one called Pamelor, which is sedating, an old one called Norpramine or Dizipramine, which is non-sedating. They can be very effective. It takes about 3 weeks to build up in the system, but they work on spinal cord nerve conduction and brain nerve conduction to slow down transmission of pain signals. Very, very, very helpful group of drugs. And sometimes they can actually be doubly beneficial because people with chronic pain don't sleep. So these sedating tricyclics can produce pain relief and sleep non-addictively. Newer drugs called SNRIs, or serotonin norepinephrine reuptake inhibitors, like Effexor and Cymbalta, can be also effective in alleviating pain. The newest one, Cymbalta, has been found to be very effective in treating chronic pain like diabetic nerve pain, chronic alcoholism causes nerve pain, other spinal pain-like conditions. They work similarly to the older tricyclic antidepressants but have a lower incidence of side effects. Anticonvulsants or anti-seizure drugs. This can be like Dilantin, like Tegretol, Topamax, Depakote, Neurontin. A wide variety of different medicines initially used only for seizures were found to say, oh my goodness, they slow down nerve transmission in the pain fibers of the spinal cord and they reduce the sensation of pain in the brain. I think I'll use this in my chronic pain patient and not produce addiction. One of the best of these is called Neurontin, now available generically, and gabapentin at much lower expense. Works like a charm in many, many patients. We can build it up to high doses, so the initial dose might not work and won't work until we double or triple the starting dose. Very effective, safe, non-addictive medication. Another one called Lyrica is pretty good, but it produces cravings in a lot of people with addiction, so I try to get by without it. We have peripheral counterstimulation. What does that mean? That means essentially we use a safe electrical discharge to confuse the nerve that's carrying up the signal. So the pain signal is going up a nerve. We turn up a little nerve generator that produces electricity on the skin that's transmitted down to the nerve painlessly, and the nerve kind of loses its interest in conducting that pain signal up the spinal cord to the brain. Very effective and totally under the patient's control. Very mild electrical discharge just from a little 9-volt battery. Manual therapies such as massage can be very effective. Physical therapy for joint manipulation, totally non-addictive, of course, totally safe, no side effects, can be very effective in people with chronic pain. relaxation training, guided imagery, biofeedback, conscious breathing, meditation. These can all be extremely effective. If people are taught to do it, they take control of their own chronic pain relief. These are not hocus pocus. They have proven relief in a lot of people. Now, what else can we do when we have to prescribe medicine for these very common conditions? Well, what must we avoid in patients with addiction, this chronic horrible illness? Doctors and patients must know that these addictive tranquilizers need to be not used. The worst of the worst is Xanax or alprazolam. Ativan and Valium are terrible drugs for treatment of anxiety and recovering opiate addicts. Most doctors don't know that. They don't teach that to most doctors in medical school. So if you have a loved one or you're in recovery and you have a lot of anxiety, don't come out with one of these prescriptions. It'll either trigger you back to opiates or you'll get hooked on these tranquilizers. Very, very dangerous group of drugs. What can we take for severe anxiety when we're in recovery or depression? There's a lot of very safe medications, very, very effective, very low incidence of side effects, no relapse triggering whatsoever. A lot of these are also in the antidepressant class. A lot of these are in the antipsychotic class or major tranquilizer class. Only a doctor can know for sure whether it takes a DEA number to prescribe one of these. If it does, we don't want it. If it can be written by a doctor with a medical license but not a DEA license, we know that it's safe in most cases. Old sleeping pills. What do we do for sleep when we have acute and chronic pain? We don't want to use addictive drugs. These are just like Xanax and Valium. They're kissing cousins. They're not around much anymore. They've been replaced by just as dangerous drugs like Ambien and Sonata, which are advertised and they look safe on TV in these commercials, but they're not safe for recovering people to take. They're habit forming, they're addictive, they're mood altering, and they will trigger cravings. So what else must we not do? Go out and buy an over-the-counter sleeping pill. Most of them have Benadryl. The generic name is diphenhydramine. Wait a minute, am I saying that diphenhydramine or Benadryl is addictive? Absolutely not. But it is mood altering. And people in recovery, when we get mood altered, we get triggered, we have cravings. We don't want to take anything with the letters PM on it because that means it's got Benadryl in it. We don't want this stuff. What can we take? Prescription Rosarum, very safe, very effective. Prescription Trazodone, brand name Deserel, but usually sold as generic Trazodone now. Inexpensive, safe, good sleep inducer, non-addictive. Old tricyclic antidepressant like Elavil or Pamelor, like I talked about before, or another antidepressant called Remron. Very safe, beneficial side effect of sedation, non-relapse triggering, non-addictive. Okay. What else do we do? Melatonin is probably okay. 1, 2, or 3 milligrams of melatonin over the counter is probably okay to help sleep. Warm milk, sleepy time tea, white noise in the background, reserving the bed and bedroom for sleep activities and sex, but not for studying and watching TV. So we train our brain to sleep. Good sleep hygiene is what this is called. Okay. At a later time, we're going to talk about the last medication that's been recently brought out and okayed for treatment and opiate agonist therapy. This is the generic name buprenorphine, sold under the brand name of Suboxone, and we'll be talking about that shortly.